Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, I want to continue with some discussion that we began on another video. In today's video, this is actually number 2 in a 2-part video series. And our general discussion over the course of these 2 video series involves range of motion testing. Range of motion testing. Now on video number 1, we talked about many issues related to what the AMA guides refer to in chapter 15 as muscle guarding, and I hope you had a chance to view that video. If you've not seen that video and you have an interest in the topic of muscle guarding and providing for permanent impairment related to the physical examination finding of muscle guarding, I recommend that you look up that video. It is available on my website. It's simply entitled Muscle Guarding. And in that video, we talked about the physical examination findings required in order to document permanent impairment under the DRE category number 2 for muscle guarding. So that's an important video for you to review. And in that video, we go over several concepts related to range of motion and how muscle guarding can impact range of motion. So in that sense, we sort of handled range of motion and the applicability of range of motion findings to the DRE categories for spinal impairments. Now in this video, video number 2, we want to talk about the range of motion method of providing for permanent impairment due to spinal injuries and spinal conditions. So we're in chapter 15 with these 2 videos. And today what I want to talk to you about is I want to talk to you about several issues related to our range of motion testing under the range of motion method for providing for permanent impairment due to spinal injuries and spinal conditions. And for the balance of today's video, I want to focus on issues related primarily to the lumbar spine, although some of the concepts that we talk about here today, of course, will apply also to the thoracic spine and the cervical spine. But I want to limit our discussion for the purposes of today's video to the lumbar spine because the AMA guides is quite clear about a set of procedures that we can employ to assess for validity of our lumbar spine range of motion measurements. It's quite interesting, and I'll get into more depth on this topic in our next segment. But it's quite interesting that the AMA guides and the authors of the AMA guides are quite concerned about validity, consistency, reliability, reproducibility, and the AMA guides is largely skewed towards what they refer to as true objective findings. In other words, the AMA guides moves away from subjective complaints and subjective findings and subjective factors and is heavily weighted toward the objective findings. And if you have a chance to review the AMA guides chapters, you'll quickly notice that the AMA guides are quite concerned about consistency and validity of our physical examination findings. And I'll give you some specific references on that in our next segment. So with regards to the lumbar spine, the AMA guides provide for us a procedure to use to determine that if indeed our examinee is providing for us lumbar spine range of motion measurements that are true, accurate, and valid indicators of a full effort by the examinee. And the AMA guides are quite clear in saying that if the lumbar spine range of motions do not pass validity criterion, then any permanent impairment due to loss of at least lumbosacral flexion extension are disqualified. So here the guides emphasize the importance of us as examiners paying particular attention to the consistency and validity not only of our range of motion measurements, but of course to all of our physical examination procedures. And I'll highlight that as well as we get into our next segment. So I want to review with you some of the factors and considerations involving the lumbar spine flexion and extension testing and lumbar spine flexion and extension validity findings. And I think you're going to find this material to be very enlightening. And what you're going to hear today is a discussion that I'm certain you've not heard anywhere else. And this is material that you cannot find anywhere else. So I want to give you a minute to go ahead and get your AMA guide so that you can follow along with me. And for today's video, I'm going to insist that you actually do get your AMA guides, because I'm going to be pointing to some specific references and citations that I need to have you follow along with me so that we're on the same page as we flow from point to point and topic to topic through today's discussion. So I'll give you a minute now to get your AMA guides, and I'll come back with you in a minute myself after I get my AMA guides, and we'll begin today's discussion regarding lumbar spine flexion and extension validity findings. Now, and have my AMA guides. I hope you have your AMA guides, because you're going to need them. We're going to go through some passages, and I want you to be able to see what I'm seeing and refer to what I'm referring. So if you haven't done that so yet, please take a moment and get your AMA guides. And when I say I have my AMA guides with me today, I'm talking about AMA guides plural. I have with me today, in addition to the AMA Guides 5th edition, I also have with me here the AMA Guides 6th edition. And I don't know how many of you out there have the AMA Guides 6th edition. But I'm going to be citing some references from the AMA Guides 6th edition simply to support the philosophy that I'm establishing here in today's video regarding range of motion testing. So the first point that we want to establish in this segment is the AMA Guides concern, or I should say the authors of the AMA Guides concern for consistency, reliability, and validity of our physical examination findings. Because really, when we get down to it, the bottom line and the end goal is for us as evaluators to come up with opinions and conclusions that are true and accurate representation of our examinee's actual condition. And that's all the parties want us to do, is to provide opinions and conclusions that are a true, accurate representation of the examinee's actual condition. And this is a philosophy that's woven throughout the AMA guides. So in order to establish that point before we get into specific issues related to lumbar spine range of motion testing, I just want to go through a couple references in the AMA guides to illustrate this concept. And we can really pick out almost any chapter in the AMA guides and see this philosophy touched upon. But I'll start us off here in chapter 18 just with a couple of basic quotes from the guides to establish this principle. This is out of chapter 18 on page 581. The guides tell us that prospective studies consistently show that the onset of disabling pain is highly associated with such factors as job dissatisfaction, lack of support at work, stress, and perceived inadequacy of income. Once initiated, the progression of pain to chronicity is contingent on similar factors. So here in the AMA guides in chapter 18, the AMA guides openly discuss that many times there's other factors lack of support at work, job dissatisfaction, and all these things that introduce subjectivity into our examination and into our examinee. Well, what the AMA Guides asks us to do as evaluators is to attempt to, as much as possible, to strip away the subjectivity and get to the bottom line objective findings. And when we get to bottom line objective findings, the AMA Guides provides for many different charts and chapters and tables wherein we can provide for permanent impairment when and if it exists in our examinee. Another quote on very next page, chapter 18. This is a section entitled Assessing Behavioral Reliability. And as I said in the introduction, the AMA Guides are very concerned about reliability, credibility, validity, reproducibility of our findings. So this is a section entitled Assessing Behavioral Reliability. They say that the principal gauge of pain is its associated behaviors, which include reports, which is reports from the examinee. Thus, the guides tell us, it is critical that this measure of pain be assessed for reliability. Here the AMA Guides bring up that word again, reliability. They require us as examiners to assess our examinee's reports of pain for reliability. They go on to say that inappropriate pain behavior, embellishment, and symptom magnification are common, particularly in medical legal circumstances and in entitlement programs. So these are not my words. These are words directly from the AMA Guides. The AMA Guides are telling us that reliability and consistency is their primary concern. Finally, just another quote out of chapter 18. Chapter 18 on page 585 tells us that it asks us to determine, let me rephrase, different quote. Chapter 18 at the top of the page of 585 says, some individuals are seen whose symptoms resemble no organic condition, who have inconsistent and non-physiologic exam findings. So the guides tell us that we can expect some examinees to present to our evaluation and provide us with physical examination findings that are inconsistent and are not related to any organic condition. Well, today we're talking about the physical examination findings of lumbar spine, range of motion. And again, in chapter 15, the AMA Guides express their concern about ensuring that our examinees provide for us measurements that are true and accurate indicators of their best effort on lumbar spine range of motion testing. So let me give you a couple of quotes now from chapter 15, the spine chapter, and then we'll get into some nuts and bolts procedures related to lumbar spine range of motion testing. This is on the top of page 374 under history. It says the history should be based primarily on the individual's own statements rather than second-hand information. It says if information from the individual is inconsistent with what is known about the medical condition, comma, circumstances, comma, or written records, comma, the physician should report and comment on the inconsistencies. Can you imagine this? the AMA guides discuss inconsistencies multiple times because it's the author's intent to guide us as evaluators to arrive at consistent opinions and conclusions, to provide for permanent impairment when and if it's present that's a true and accurate representation of the examinee's true condition at the permanent and stationary time, or permanent and stationary date, or I should say it's representative of their permanent and stationary condition. And so the guides openly discuss inconsistency, and they demand of us that we report on any inconsistencies and non-physiologic exam findings. And I'll relate that to lumbar spine range of motion in just a minute. Very next page, on page 375 in chapter 15, it says that the physician should record and discuss any physical findings that are inconsistent with the history. Many physical findings are subjective, meaning that they're potentially under the influence of the individual, which is our examinee. It is important to appreciate this and not confuse such observations with truly objective findings. We're going to talk about how to arrive at truly objective findings with our lumbar spine range of motion testing. Okay, and then finally, this is under chapter 15 under the range of motion method heading, section 15.8 on page 399. So 399, second column, second paragraph, states that the physician should seek consistency when testing active motion. We're talking about our range of motion testing. The physician should seek consistency. The reproducibility or the precision of an individual's performance is one indicator. It's one indicator, but not the sole indicator, of optimum effort. It's one indicator. The reproducibility of the measurements on lumbar spine range of motion is one indicator of optimum effort. They're telling us that the examinee should provide consistent measurements over a series of testing. When measuring range of motion, the examiner should obtain at least 3 consecutive measurements, and if after 6 measurements inconsistency persists, the spinal motions are considered invalid. The measurements and accompanying impairment estimates may then be disallowed in part or in their entirety. So let's just put this into perspective now. The AMA guides establish a philosophy based on objective findings, truly objective findings. And they tell us that with regards to lumbar spine range of motion testing, many times it's difficult to obtain range of motion measurements that are consistent. Number one, that are consistent measurements over time and over repeated testing. But also that it's difficult to obtain measurements that are consistent with the examinee's condition, because many times examinees will provide physical examination findings that are inconsistent. The AMA guides clearly established that, and I gave you several citations for that. Well, it's amazing because with regards to range of motion testing, the potential for inconsistency is so great, and range of motion measurements are so unreliable and so inconsistent and vary so much between examiners. In other words, range of motion tests have poor inter-examiner reliability. And it's such a problem that the AMA Guides 6th edition has completely disallowed range of motion findings in the provisions of permanent impairments related to the spine. So I don't know how many of you have the AMA Guides 6th edition. Now in California here, we still rely on the AMA Guides 5th edition. But in some jurisdictions, in some states, the legislative language states that they will always use the most recent edition of the AMA Guides, and the 6th edition is the most recent edition. In California, our legislative language with the passage of Senate Bill 899 was that we will use the AMA Guides 5th edition. So even though AMA Guides 5th edition was published, I believe in like the year 2000, we adopted it in 2005, but I believe it was published in 2000. AMA Guides 6th edition published in 2005. So even though the 5th edition was published in 2000, here we are in almost 2015, still relying on the AMA Guides 5th edition. But in the AMA Guides 6th edition, they tell us in the very beginning of the spine chapter, which is chapter 17 in the AMA Guides 6th edition. But they tell us right at the beginning of the chapter, they say that range of motion is no longer used as a basis for defining impairment, since current evidence does not support this as a reliable indicator of specific pathology or of permanent functional status. So what does that mean? What that means is, according to the authors of the AMA Guides, which we consider to be a credible reference, correct? They tell us that loss of range of motion is a poor indicator of any specific pathology, meaning if you identify an examinee with reduced spine range of motion, what specific pathology does that indicate? There is no one single specific pathology that decreased range of motion points to. And so it's a poor indicator of any pathology. Second, loss of range of motion is not a reliable indicator of an examinee's permanent functional status. And so the AMA Guide 6th edition has completely done away with range of motion as an indicator or as a contributor to permanent impairment. So quite interesting. Well, we still use the AMA Guides 5th edition, and we rely on the AMA Guides 5th edition. And so the AMA Guides 5th edition does require that we perform range of motion testing. And so we're going to talk about how to perform range of motion testing and how to establish the validity and consistency of your range of motion findings. So we'll get right into some meat and potatoes regarding that in our very next segment. Let's now talk about the lumbar spine range of motion testing. Imagine that you have an actual examinee in front of you, and it's now time to do your measurements. Well, the first thing I recommend is that you perform your range of motion testing at the very end of your physical examination procedure. That it's the very last procedure of the entire examination that you perform. And the reason for this is that the AMA guides require that we thoroughly warm up our examinee prior to obtaining range of motion measurements, so that the measurements that we do obtain are accurate and are not limited by stiffness, tightness, cold muscles, adhesions, etc. So what you can do is you can perform a brief range of motion warm-up at the beginning of your evaluation and assess the examinee's range of motion by visualization, not by measurement, but by visualization at the beginning of the examination procedure, but perform your measurements at the conclusion of your examination. This serves to warm up the examinee at the beginning of the evaluation, and then also as you go through your examination procedures with the examinee standing, examinee sitting, examinee supine, and examinee prone, and all the maneuvers that you go through, including straight leg raise testing and hip flexion testing and manual and passive manipulations of the lower extremities, all of these serve to warm up the examinee so that by the time you get to the actual measurements, the examinee is loose and is ready to provide you measurements that are an accurate representation of their true capacity. So that's the first thing. I recommend that you do the range of motion measurements as the very last procedure in your examination procedure, almost immediately before you discharge the examinee from the evaluation completely. That's the first thing. Second thing is, let's talk about inclinometers. The AMA guides require that we obtain these measurements through the use of inclinometers. And there's many kind of inclinometers on the market. I have my inclinometers here. And my inclinometers, I'm not sure if you can see this, I use digital inclinometers. And I don't know if you can see the printout display calibrating the range of motion, but this captures range of motion measurements from both instruments and does any necessary additions or subtractions within the software of the device itself. Now I like this digital range of motion inclinometer because it provides for precise numeric single-digit readouts of range of motion. In my opinion, accurate and single-digit, or I should say accurate to the digit, readouts are much more compelling and much more persuasive than our range of motion measurements that are simply rounded to the nearest 5 degrees. So I recommend that you report your range of motion measurement findings to the nearest one single degree. And I'm sure you've read medical records where you've seen the range of motion measurements that are rounded to the nearest 5 degrees, and you'll see measurements such as lumbar flexion 45 degrees and lumbar extension 25 degrees and left lateral bending 20 degrees. And it's my opinion that accurate to the digit measurements are what you should report, because accurate and to the digit measurements are much more persuasive and much more accurate and much more compelling. So record your measurements such as 21 degrees, 27 degrees, 34 degrees, 39 degrees, rather than simply rounding to the nearest 5 degrees. Okay? So it's now time to do our lumbar spine range of motion testing. Well, the first step in producing and obtaining our measurements involves capturing the sacral flexion and sacral extension angles. Now, the sacral flexion and sacral extension angles are important for at least two reasons. First of all, reason number one is that table 15.8 of the AMA guides, that's the table that we refer to when it comes time to provide for permanent impairment for loss of lumbar spine, flexion, and extension. Well, in that same table, we also provide for permanent impairment for loss of sacral flexion angle when there is concomitant, or I should say concurrent, loss of lumbar spine, flexion, and extension. So imagine this: if you want to pick something up from the floor, that activity requires contribution from multiple joints. It requires that you be able to flex your spine. It also requires that you be able to flex at the hip joint. Well, imagine a person or an examinee who has loss of 50% range of motion of spinal flexion. That's going to make it difficult for them to do activities at and below the waist level because they simply have loss of capacity for bending. Well, if that examinee has simultaneous loss of hip flexion, his capacity to reach down below the knees and do activities at and below knee level is severely impaired. So the AMA guides consider the hip flexion angle or the sacral flexion angle along with lumbar spine flexion angles in providing for permanent impairment. So that's one reason. The second reason that we obtain the sacral flexion and extension angles is that the AMA guides provide for a validity testing procedure that the examinee must pass in order for us to consider the lumbar spine flexion and extension angles at least to be considered valid measurements. So we're required to obtain the sacral flexion and sacral extension angles. So we do that with our inclinometer. So with our inclinometer, we place our inclinometer on the spinous process of the first sacral vertebra. Now the sacrum, as you'll remember, is composed of 5 fused vertebrae. There is no intersegmental motion between the individual vertebrae of the sacrum. So the sacrum is one fused bone that moves en bloc. So we place our inclinometer over the spinous process of the first sacral vertebra. And we ask the examinee to bend forward and touch their toes. As the examinee bends forward to touch their toes, we capture the movement of the sacrum bone. Now, the inclinometer is adhered to the sacrum bone, and the sacrum bone moves as the pelvis rotates around the hip socket. So when we measure the sacral flexion angle, we're measuring the flexion of the pelvis to which the sacrum is attached and to which the sacrum is an integral part of the pelvis. We're measuring the movement of the pelvis around the fixed hip socket. The hip socket is fixed because the feet are firmly planted on the ground and the leg is fixed. Now later on we're going to come back and we're going to compare this measurement that we obtained on sacral flexion with we're going to compare it to the finding of the straight leg raise testing. Now with the straight leg raise testing procedure, we're testing the same motion as the sacral flexion motion. We're obtaining the same angle with straight leg raise testing as we are obtaining with sacral flexion testing. The difference is that with sacral flexion testing, we're measuring the rotation of the pelvis around the hip socket. With straight leg raise testing, we're measuring the rotation of the leg around the pelvis. They're the same motion. They're the same motion. And I'll illustrate that as we go on. You know, in the exercise sciences, there's a concept known as the open and closed kinetic chain exercises. Open and closed kinetic chain exercises. So for example, if we consider all the joints of our body to form kinetic chains, we can consider that those chains are either open kinetic chains or closed kinetic chains. And let me illustrate those to you now. For example, consider the upper extremities. The upper extremities are composed of multiple joints, all arranged and all functioning in a kinetic chain. Well, if we consider the most distal joints of the upper extremity, if the most distal joint of the upper extremity is mobile, while the proximal joints are fixed and stabilized, we call that an open kinetic chain. We're referring to the distal aspect of the extremity. So for example, an open kinetic chain upper extremity exercise would be, for example, bicep curls. With bicep curls, the distal aspect of the upper extremity is the mobile portion of the upper extremity, and the proximal segment is fixed and stable. What would be an example then of an upper extremity exercise involving a closed kinetic chain? Meaning that the distal aspect of the extremity is fixed and the proximal attachment of the extremity is the mobile portion. Instead of the hand moving, the torso would be moving. Well, how about pull-ups, where we grab a pull-up bar and our hands are fixed on the bar, and yet our torso moves up to the bar. The hands don't move, the hands are fixed. The distal aspect of the upper extremity is fixed in the closed kinetic chain. Well, sacral flexion testing and straight leg raise testing are just variations on this open and closed kinetic chain. When we measure sacral flexion, the distal aspect of the lower extremity, meaning the foot, is adhered to the ground, it's fixed, while the upper portion of the chain, the trunk, the torso, the pelvis, rotates around the fixed hip or the fixed leg. The leg is fixed. With straight leg raise testing, with the examinee supine on the examination table, here we fix the torso to the table and we move the leg in relation to the torso, an open kinetic chain. They're just variations of the same movement. They're the same movement. They're the same movement. That's why the AMA guides use the straight leg raise test as the validity test for sacral flexion and extension. So let's talk about this a little bit. Imagine that you have an examinee doing sacral flexion measurements. Now, what are some of the limiting factors to sacral flexion measurements and sacral flexion motion? Let's think about this. Well, one of the things that I want you to think about are some standard positions and standard activities that take the sacrum and the hip through flexion motions as a part of normal activity. For example, as you see me here sitting on this examination table, and I'm not sure the camera captures the whole view of my torso, but as I'm sitting here with you on this examination table, my hip is flexed on my pelvis 90 degrees. So if you were to observe me sitting here, you know that I have at least 90 degrees of hip flexion by virtue of the fact that I can sit with you here upright. If I then turn over on my back and I disallow you to flex my hip on my pelvis 90 degrees, that would be considered an inconsistent examination finding. Those would just be different examples of the open and closed kinetic chains. Same motion. Okay? So let me demonstrate even an increasing sacral or hip flexion angle. What if I was to bend forward in my chair like this and increase my hip and sacral flexion angle? I can go as far as bringing my chest all the way down to the tops of my thighs. This is the hip flexion angle in a non-weight bearing, non-standing position. Now in chapter 17, the AMA guides refer to normal hip flexion as at least 110 degrees. The first level of impairment, the mild impairment due to loss of range of motion of the hip, begins at 100 degrees. So the AMA guides consider normal range of motion to be 110 or greater. Well, as I sit here in front of you now, and we took a goniometer out, you'd see my hip flexion angle probably about 130 degrees. So just by virtue of the fact that I'm sitting here, you know that I can flex my hip on my pelvis at least 90 degrees. Okay? Now, when we stand up and become weight bearing, things change a little bit. And we start to see reduced sacral flexion angles. Why is that? Why are our sacral flexion angles lower when we're in the weight bearing position than we are when we're in either a sitting position or a supine position? Well, in order to answer that, I want to diagram that out for you. So let's bring into view our whiteboard, and we'll diagram out a couple of things. Okay, I hope you can see this. So let's go over the anatomy of sacral and hip flexion. Here we have an examinee standing in the upright position. Here's the foot, here's the lower leg, here's the knee, here's the thigh, here's the hip joint, here's the acetabulum of the pelvis, here's the sacrum bone, and here's the lumbar spine vertebrae. And let's put a little lordosis in there. Okay? So here's our examinee. Well, when we test for sacral flexion, we place our inclinometer right here on the first sacral vertebrae. So there's our inclinometer. And we ask the examinee to bend forward, reaching for his toes. What are the limiters to that range of motion? What factors limit or restrict or check or control that range of motion? Well, the primary check and the primary limiter to the full range of motion of the sacral flexion measurement, sacral flexion motion, is the hamstring muscles. The hamstring muscles attach below the knee, and the hamstring muscles cross the knee, come up and cross the hip, and attach on the pelvis on the ischial tuberosity. The hamstring muscles are bi-articular because they cross two joints. They cross the hip joint and they cross the knee joint. They're bi-articular. So remember that the hamstrings consists of four muscles. You have the semimembranosus, semitendinosus, the long head of the biceps femoris, and the short head of the biceps femoris. Of those four muscles, three of the four cross the hip joint to attach on the ischial tuberosity. Four of the four, all four of them, cross the knee to attach below the knee on either the tibia or the fibula. So three of the four hamstrings are bi-articular. Well, as this examinee now goes to bend over and touch his toes, the leg remains fixed and the torso or the pelvis rotates about the acetabulum. Here's our vertebrae. We'll put a lordosis in there. 5, 4, 3, 2, 1, T12. And now you'll notice that the inclinometer has moved. And we record that measurement. Now, as the examinee moves forward, flexing the sacrum around the hip joint, the hamstring muscles begin to tense and tighten. And the hamstring muscles begin to become stretched across the hip joint as that pelvis rotates around the acetabulum. Well, there comes a point in time when the hamstring muscles can no longer stretch any further and can no longer elongate enough to allow further rotation of the pelvis around the acetabulum. When the hamstrings reach their maximum length and their maximum capacity to elongate, we say that the hamstrings have reached what's known as passive insufficiency. Passive insufficiency. Passive insufficiency is a concept that refers to biarticular muscles such as the hamstring, and it refers to their ability to fail to continue to elongate across both joints simultaneously. So our sacral flexion measurement reaches its maximum when the hamstring muscle reaches passive insufficiency. Now, how can you tell when your examinee has reached passive insufficiency? Well, you can tell that when your examinee has reached passive insufficiency because what will happen is the examinee will flex at the knee. The examinee will flex at the knee. When they flex at the knee, that slackens the hamstring muscles at the knee to allow additional length at the hip to allow the pelvis to further rotate around the acetabulum. And the examinee can go a little bit further because they've provided slack here at the knee. So you'll know that you've reached your maximum sacral flexion angle when the examinee begins to flex at the knee. Knowing this, you realize that the sacral flexion measurement is actually a measurement of the hamstring flexibility. When the hamstrings can no longer elongate, as evidenced by bending at the knee, we've captured the maximum sacral flexion measurement. Now notice in this diagram here, if we put the inclinometer where it goes, you notice that the inclinometer continues to record greater and greater angles. But it's not an accurate angle because we're adding in motion at the knee. It's when the knee begins to bend and we reach passive insufficiency is when we capture our sacral flexion measurement. So let me demonstrate this to you. Okay, so imagine this. We place the inclinometer on the first sacral segment here, on the spinous process of S1 vertebra. Now, as I begin to flex my sacrum, you'll notice that I can flex my sacrum without introducing any motion at all in the spine. Notice here, I'm flexing my sacrum, but my spine has not moved at all. And I can continue to flex and continue to flex and continue to flex until my hamstrings reach a point at which they can no longer flex any longer. They can no longer stretch or elongate any longer. If I continue to go lower, which I can, I have to release the tension in my hamstrings at the knee, and I can go lower, lower, lower as I increasingly flex at the knee. The sacral flexion angle is captured when the hamstrings reach passive insufficiency, which in my case is right about here. If I go any lower, my knees bend. So it's right about here. I want you to remember this because we're going to look for this flexion of the knees when we do the straight leg raise testing with the examinee supine. Okay? Now let's put this together. Now here I'm doing sacral flexion with no spinal motion at all. I have not moved my lumbar spine. Once I get to the end of sacral flexion, if I want to go lower without bending my knees, then I can bend my spine. That's spinal flexion. Right now we're not considering spinal flexion, we're simply considering sacral flexion, which is a measurement of the flexibility of the hamstring muscles. Now, imagine this. This is the case of the closed kinetic chain. This is the closed kinetic chain. Now, when we place our examinee supine and compare this measurement that we obtain on sacral flexion with the straight leg raising angle, here we have our examinee supine on the examination table, and for measuring the straight leg raising angle, we put our inclinometer here. We put our inclinometer here. And here we raise the leg this way and capture our measurement. We'll know that we've reached passive insufficiency when we get the leg up as high as it goes, but the knee starts to bend. Once we get a flexion at the knee, the purpose of which is to relax the hamstring muscles, we know that we're at passive insufficiency and we capture our straight leg raise angle. Now, interesting question. And this is where it comes into establishing our validity measurement. We're going to find that the AMA guides provide for a larger measurement here than they provide for a measurement here. In other words, the AMA guides allow a greater straight leg raise angle measurement compared to the sacral flexion measurement. Why is that? Why is that? They're the same motion. They're the exact same motion. It's just the open kinetic chain versus the closed kinetic chain. But why does the AMA guides allow for additional motion in the supine straight leg raise than they do for sacral flexion? Well, let's talk about that. Okay. Okay, so let's talk about that. Well, with sacral flexion compared to the straight leg raise angle, there's a couple things that can limit the range of motion of the sacral flexion angle as compared to the straight leg raise angle. So imagine that you have the examinee in the standing weight-bearing position and they reach over to bend their toes so that you can capture the sacral flexion angle. Well, as the examinee bends over, initially this can be done with no motion of the spine, and I demonstrated that to you. So imagine that the examinee is not bending the spine. Well, even so, as they go to bend over, there still is isometric contraction of the lumbar paraspinal muscles, the longissimus thoracis, the spinalis thoracis, the iliocostellus. These erector spinae muscles contract isometrically to keep you from flopping over like a wet dumpling. And in the presence of pain, this muscle contraction can limit and can interfere with motion. So there's one example. Another example is that as the examinee goes to bend over and the torso moves anterior relative to the lower extremity, the anti-gravity muscles such as the hamstrings and the gluteal muscles, these muscles contract eccentrically. They lengthen eccentrically to control the downward motion of the torso. And when you get to your maximum flexion angle, there still is resting and eccentric tone in these muscles that limit full elongation. This is what keeps you from slumping forward like a wet noodle. And so these factors contribute to a reduced sacral flexion angle compared to the straight leg raise angle, even though both motions are the same motion. So the AMA guides acknowledge that the sacral flexion angle is less than the straight leg raise angle. But it's fascinating because the AMA guides provide for at least 2 corrections to bring the sacral flexion angle up to a point where they consider the sacral flexion angle to be a valid indicator of an optimum effort by the examinee. So the 2 corrections that the AMA guides provide are as follows. Number 1, the AMA guides allow us to add in the sacral extension angle, to come up with what they call the sum of the sacral flexion and sacral extension angles. Now, in a perfect world without gravity and without muscle tension, the sacral flexion angle would be the same as the straight leg raise angle. They would be the same. But the AMA guides acknowledge that pain can limit motion, resting muscle tone can limit motion, and so they allow us to add in the sacral extension angle to come up with the sum of the sacral flexion and extension angle. So there's the first correction that the AMA guides allow in order to bring these measurements closer to the straight leg raise angle. That's one correction. The second correction is that the AMA guides give us a range of 15 additional degrees. 15 additional degrees. Now imagine, first of all, that you have a sacral extension angle of 15 degrees. The AMA guides allow us to add that into the sacral flexion angle to bring it closer to the straight leg raising angle. Should be pretty close, correct? If we add in the sacral extension angle, well then on top of that, they give us 15 additional degrees to bring the sum of the sacral flexion and extension angles up to the straight leg raise angle measurement. And the AMA guides tell us that if the addition of these 2 additional correction factors, number 1, the addition of the sacral extension angle, and then number 2, the addition of 15 additional degrees buffer, if the addition of these 2 correction factors doesn't bring the sacral flexion angle identical to the straight leg raise angle, then they consider the effort on sacral flexion testing to be invalid and not representative of a true effort by the examinee. Now, if this seems like a roundabout procedure, it kind of is. And some textbooks other than the AMA guides describe what I consider to be much more accurate measurements for spinal flexion. For example, one reference describes the use of a tape measure. The end of one end of the tape measure adhered to the first sacral spinous process. The other end of the tape measure adhered to the spinous process of T12, and then the examinee is then asked to flex forward at the lumbar spine, such as what I'm doing here in front of you. And the elongation of the tape measure is then recorded as spinal flexion. Because as the lumbar spine flexes, the spinous processes separate. That increasing distance is captured on the tape measure, and this is one way that lumbar spine flexion is measured. Another way to measure lumbar spine flexion would be to simply have the examinee seated, as I'm seated here in front of you. And the first inclinometer could be placed on the first sacral segment, second inclinometer could be placed over T12, and then I'm asked to simply flex forward here at the spine, keeping my hip flexion angle relatively constant. And we're capturing here simply true lumbar spine flexion. But the AMA guides introduce the weight-bearing position. They compare it with a non-weight-bearing validity test procedure, and it's quite confounded. But it's what we have in the AMA Guides 5th edition, and as I said in the introduction to this section, in the AMA Guides 6th edition, they've done away with range of motion altogether as a contributor towards the permanent impairment. So how do we summarize all this? We summarize all this by saying that the AMA guides are concerned with lumbar spine validity testing, and they give the examinee at least 2 generous buffers, one of which is minimum 15 degrees, the second of which is the totality of the sacral extension measurement. They allow us to add those in to bring the sacral flexion angle up to the straight leg raise angle measurement. And so they give the examinee considerable added credit for these additional ranges of motion. So if the examinee is still unable to provide a sacral flexion angle that comes close to the straight leg raise angle measurement, it's simply indicative of a poor effort, because as we indicated in the introduction, these are the same motions with the examinee, just in different positions.